Check, 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 check. Mic check. 1, 2. 1, 2. Mic check. Check, check, 1, 2, 3. Check, check, 1, 2, 3. Audio check. Audio check, 1, 2, 3.
Audio check 1, 2, 1, 2, 3. Audio check, check, check.
Test 1 2. Power 1 2 3. Test 1.
Here, and we're going to have the speakers all introduce the next speaker. So
Oh,
we're going to
okay.
introduce them.
Okay. Does everyone know that?
I'm letting everybody know. I think Dr. Prava is the only person I need to.
Okay. Okay.
And then the speakers are going to be controlling the slides themselves with
Okay.
this clicker.
Okay.
I think we're all set.
Okay.
Quite a few speakers.
Power 1 2. Test, test, test. Power 1 2. Way up. Test 1 2. Test 1 2. Okay. How's it now? Is that a little bit cleaner? Test 1 2. Power 1 2.
Yep. Test, test. Good afternoon. If everyone can take their seats. Thank you for joining us. To kick things off, I want to introduce Dr. David Carlisle with Charles Drew University.
Well, I want to, this is really an exciting moment. It's standing room only, which is hard to do in this lobby. But I think it symbolizes the importance of having our colleagues and friends from the LA County Department of Public Health here with us on campus. And I'm here to just say welcome on behalf of everyone at CDU. We have some of our medical students here. We have other students here, nursing students. We have faculty members here. We have staff here, all in celebration of the work of the Department of Public Health and recognizing their great leader, and that, of course, is Department Director Dr. Barbara Ferrer. And, every once in a while, heroes emerge. And during the COVID-19 pandemic in Los Angeles, we had a hero emerge here in Los Angeles. And I know that it was difficult. And, this was a politically difficult event as well as a public health challenged event. And I know that, you had some demonstrators and pickets that you had to deal with and things like that. But that's part of being a healthcare hero. And if you haven't heard that already, that's a new term that we're going to be using at CDU, healthcare hero. It's an honor for me to welcome an LA County healthcare hero, Dr. Barbara Ferrer, to our podium. Dr. Ferrer.
Good morning, everyone. Well, really good afternoon, and thank you so much, Dr. Carlisle. I do want to just start by saying Pretty much everybody in this room is going to be able to call themselves, or can already call themselves, a healthcare hero. You're all here because you're compassionate, you care a lot, but you're also dedicated to social justice, because that's what this institution stands for. So I want to have everyone join me in applauding all of you, particularly our students. I also want to congratulate the leadership here, the faculty here, and the medical school students, for this just amazing opening of a 4-year medical school last year. And how proud you should all be of this just spectacular accomplishment. And I wonder if the medical students, I know some of you could just hold your hands up so we can all sort of give you our love and our, I'm partial, but I think all the students who are here, you are in, hands down, sort of the best institution for your training. Whether you're undergraduate or you're in a graduate program here, I've never in my life, and I'm probably one of the oldest people in the room, I've never met a more dedicated leadership team, faculty, and staff. Not just deeply committed to sort of these ideals of racial, economic, and social justice, but deeply committed to making sure that everybody who's here, workers and students, are getting the love and support that helps folks find their way. I'm a perfect example of somebody who took forever. I mean, I barely graduated from high school. I dropped out of college. Took a while for me to get my act together. And I wish I had been at this school. I just wish I had been at this school. I look at how much caring there's just built into the very structures here. And I'm envious and very proud of this amazing leadership team. And I do want to make sure that we all take a moment to recognize Carlisle, Dr. Parthros-Stith, and Dr. Vargas. If they could just all stand up. Could you guys just stand? I'm just so grateful that, I'm in LA County and I'm with amazing people every single day. But I want to acknowledge that under the direction of your leadership team, this institution's profound commitment to serving marginalized and under-resourced communities and eliminating health inequities ends up being a source of inspiration for all of us who are in public health. And again, I know that it's this team here, all of you together, that are making it possible for this future generation of healthcare professionals to be as dedicated to justice as they are to medical excellence. You allow all of us to be filled with hope for our future. And I'm also very proud of the Department of Public Health team that's here today. And I'm going to ask them to stand up. If everybody who's part of the health team. We're here today to really present the latest findings from the LA County Health Survey. But I want to acknowledge is that this team makes it possible for that information, which does not belong to us at the health department, but belongs to all of you, to actually be made accessible in ways that allow people to use this information to guide the kind of work that we all collectively need to make sure happens, which is that everybody in LA County has the resources they need for optimal well-being. There's no point in looking at data if we're not going to be able to do that collectively in a way that allows us to move to action. Otherwise, frankly, and you all know this story better than me, the data actually, especially because it consistently, and even today you'll hear, consistently shows inequities in health outcomes, particularly by race and ethnicity. These inequities, when they're not viewed in the full context of the experiences and with the full understanding of the contributions of the social determinants of health, they've been used for generations to perpetuate false narratives. So our work is to make sure that this information never gets used to perpetuate false narratives. It's always used to drive action, to promote equitable health outcomes, and our collective need to really look hard at what it's going to take to be able to realize a more just society. As we review the findings today, and we have an amazing team that will help, sort of help us all understand what we've got there, I'm reminded that behind every single data point is a person, a family, and a community. And our approach to public health must recognize the importance of also capturing the stories of the individuals and their families and their communities in order to recognize and appropriately document the profound impact of social determinants on health. I want to thank some of our presenters, so I'm just going to note that Deepa Shah is here, Deepa Shah Patel is here. Deepa, maybe you could stand up, from the Public Health Nutrition Program, and Monte Messex from our Tobacco Control Program. And I'm so proud that they were willing to come, because they're actually going to try to connect some of the dots, like how do we use this data to really inform our work and advocate for health-promoting policies. Importantly, before I close, I want to appreciate the thousands of LA County residents that took part in this survey, because I fiercely hope that the information we've gathered through this survey is going to get used by community organizations, local leaders, and residents, so that we work together to prioritize efforts to build healthy communities that promote justice for all. And I know that the challenges, they're significant. There's no doubt in my mind. Dr. Pratostith and I were working on some of these issues that you're going to hear about today decades ago. I'm not outing you, because I already said I'm pretty old. Yep. But our collective resolve, I think, is just as powerful. And it allows us to really be inspired by a belief that good health is a right for everyone. Thanks so much for your leadership. I'm so proud that I'm here today with all of you to engage in this really critical conversation. And with that, I'm going to introduce one of my dearest colleagues, somebody who has inspired me forever and taught me a lot, Dr. Deborah Pratos. So.
Good afternoon. I'm first going to add my welcome to that of Dr. Carlisle's and reassure the Department of Public Health that you're in the right place. This is the right place because of our dedication to this community, to social justice, and to looking at health, both from the medicine and the public health sides, and doing something about it. So you're here. We're so pleased that you're here. I'm Dean of the College of Medicine. There's another dean in the audience. Actually, are two more deans in the audience. And I just have to recognize them because they're both very, very special. Dean Gail Washington. Dr. Washington is Dean of the College of Nursing. We're in their building. Thank you. And Dean Monica Farini, who is the Dean of our College of Science and Health. Dr. Farini, thank you. So our colleagues across the board are dedicated to the mission of CDU. I will only add, and Dr. Ferrer did mention that we sort of worked together in Boston on violence prevention, on working with youth, on broad public health issues. And one of the things that I learned about her then that continues to today is that it isn't enough for her just to expose the problem. She is dedicated to figuring out how to get the action that's needed to correct and help communities solve problems. So as one public health professional to another, let me say thank you for who you are and for being here. I'm just, super excited because it's been since 2018, since before COVID, that we've had really good data. And while that's not enough, data give us the opportunity to highlight, advocate for, and solve problems. So as I said, you're in the right place for this. So I'm not gonna stand in the way of us figuring out and hearing about the new survey. And with that, we'll turn it over to Dr. Rashmi Shagiri, who is the Chief Science Officer from the Department of Public Health, and she's gonna tell us all about what we've got to do and what we've got to know. So thank you.
Well, maybe not quite all of that, but I will at least talk about the data. So good afternoon. It's just such a pleasure to be here with all of you and just looking out and seeing all the students who I'm really hopeful will be people who really engage with the data and will be able to take this out and in the work that you all are doing for many, many years to come. So I'm Rashmi Shagiri. I'm the Chief Science Officer of the LA County Department of Public Health, and I'm really grateful to be able to talk about the LA County Health Survey with you today. So the Health Survey began in 1997, just a little bit of history. It's been around for a while. And the purpose was to provide data to drive public health decision-making and community health improvement efforts. And it continues to be that. At the time the survey started, there really wasn't an avenue for reliable health surveillance data at the county level, especially for chronic disease prevalence, health behaviors, access to healthcare services, and public opinion on health issues. The key objectives of the survey continue now to be obtaining reliable population estimates for health indicators, identifying health disparities across population subgroups, such as racial and ethnic groups, and also at the county and sub-county levels, such as our service planning areas. Being able to track trends in health indicators has also been and remains a really important objective, as well as being able to compare our local data with state and national data. So the health survey is a population-based survey. It's designed to produce representative data for the entire county population and also for our 8 service planning areas. It's been conducted in the past every 2 to 4 years. The 2023 data are the 9th cycle of the survey. There was a little bit of a delay between the 2018 and 2023 because of this thing that happened called COVID. And we are, glad to be able to now bring the 2023 data out. It's been a while. So there are 2 components to the health survey. There's the adult survey and there's the child survey. So for the adult survey, 1 adult age 18 years or older is randomly selected in the household to complete the survey. In the past, we've had about 8,000 adults who responded to the survey. Most recently, in 2023, we had over 9,000, so that's a really good sample size. For the child survey, information about 1 randomly selected child per household is obtained from the parent, guardian, or caregiver who is sufficiently knowledgeable about the child. So in the past, we've had data on about 6,000 children, and this is children and adolescents 0 to 17 years old. And in the 2023 survey, we have over 7,000. The survey is administered in 6 languages because we know we have a lot of diversity in our county population. So it's in English, Spanish, Mandarin, Cantonese, Vietnamese, and in Korean. And then the data are weighted to reflect the overall county population and each of the service planning areas. So it doesn't just reflect the 9,000 people that were interviewed, it really reflects the whole county, which is great. So topic areas for the adult survey generally include demographics, chronic diseases such as diabetes and high blood pressure, health status, including self-rated health, health-related behaviors, social determinants of health, such as housing and food insecurity, and healthcare access indicators, which includes insurance, access to care, and utilization of preventive services. And then we also have additional special topic areas that are asked in some of the cycles and not in others, and are sometimes only asked of certain subsamples of respondents. And these include things like questions on climate change, the built environment, emergency preparedness, and then public opinions on a variety of public health policy topics. Similarly, for the child survey, topic areas include demographics, health conditions and health status, health insurance and access to care, and then for children, also childcare access and quality, child behaviors and routines, parental behaviors and perceptions about various topics, and then prenatal health, breastfeeding, and hospital practices as well. So in the next set of slides, I'll present some selected findings from the health survey data with a particular focus on identifying health inequities by race and ethnicity, and then later on by poverty level. So this is like a really, really small proportion of the data that are available in the survey. But just wanted to give you a flavor of it and some examples of how the data can be used. So this slide shows the percent of adults 18 years and older who reported ever being diagnosed with diabetes in LA County from 1997 to 2023. So when we look at the trend overall, yes, there's some like moaning and groaning going on around here. So we see that it's really been increasing over the years. It's plateaued from 2018 to 2023 at just over 11%. And this is really valuable. Are you okay? Okay. Just checking. This is really valuable information, but it doesn't really tell the full story about who continues to be impacted in the county. When we look more closely at recent trend data by racial and ethnic group, we see that our Latinx and Black populations, which are indicated by the blue and the green lines here respectively, have substantially higher rates of diagnosed diabetes compared with our Asian and white populations, which is indicated by the purple and the red lines. So this slide shows the percent of adults 18 years and older who reported ever being diagnosed with hypertension or high blood pressure in LA County from 1997 to 2023. So it's definitely has gone up and continues to go up. So when we look at the hypertension trends across the county, we see that the proportion of county residents with a diagnosis of hypertension has increased over time. In 2023, it was 27.8%. And then again, when we look at the recent trend data more closely by racial and ethnic group, we see that the rates of hypertension among our Black population, which are indicated by the green line, are consistently higher than among our white, Asian, and Latinx populations, with hypertension affecting more than 1 in 3 Black adults in 2023, compared with about 1 in 4 Latinx and Asian adults. So these inequities in health outcomes, as Dr. Ferrer, Dr. Patros talked about already, they're due in substantial part to underlying social, economic, and structural inequities in access to the opportunities and the conditions that promote optimal health. We can also use the health survey data to continue to examine some of these underlying factors, not just the health outcomes, but the things that are underlying some of these things. So for example, high quality access to healthcare is an important factor in preventing and treating diseases such as diabetes and hypertension. This slide shows the percent of LA County residents who were uninsured, that's shown in the green line, the percent of adults who did not have a regular source of healthcare, that's the purple line, and the percent of adults who had difficulty obtaining needed medical care, that's the blue line. So over the last 20 years, we've seen substantial reductions in the rates of uninsurance in the county, meaning more people are insured, which is great, but insurance alone does not mean access to care. So here we can see that increasing rates of adults, there are increasing rates in adults who do not have a regular source of health care, and an increase since 2018 in the proportion of adults who report difficulty obtaining needed medical care. So again, even though we're seeing insurance rates get better, the actual access really is not. When we further examine healthcare access by racial and ethnic group in 2023, we see that Latinx adults, depicted here by the blue bars, have high rates of uninsurance and are also more likely to report not having a regular source of care and difficulty obtaining needed medical care. Diet and nutrition also can impact diabetes and hypertension, and having enough food to eat is a basic determinant of health. So here we can see, though, that more than a third of Black and Latinx adults in the county live in households that are food insecure, meaning that they are unable to reliably afford or access enough food. This is double the rate of food insecurity among white and Asian adults. And then in LA County especially, as all of us know, the cost of housing is another significant underlying determinant of health. Families may be forced to make difficult choices between necessities such as paying for housing, quality food, and healthcare needs such as medications and healthcare visits. In 2023, 54.2% of LA County households reported spending more than 30% of their monthly income on rent or mortgage. And this was an increase from 42.1% in 2018. Almost 2/3 of Latinx and Black households reported spending more than 30% of their monthly income or rent on rent or mortgage in 2023, compared to just over 40% of white and Asian households. There's also a growing body of evidence that supports that experiences of discrimination have long-term impacts on health through multiple mechanisms such as physiologic impacts of prolonged stress and being subjected to discriminatory practices in accessing the conditions and opportunities that support health. In 2023, almost 15% of Black adults reported experiencing discrimination at least once a week, compared with almost 10% of Latinx adults, almost 7% of white adults, and almost 5% of Asian adults. One of the factors on the positive side that can promote healthy outcomes is receiving support when it's needed. Over 60% of LA County adults in 2023 reported always or usually receiving the social and emotional support they need. And this support is higher among Black and among white adults, with more than 2/3 reporting receiving the support that they need. So another important area in which we see inequities is among those who are living in poverty compared to those who are more affluent. This slide shows the percent of children 17 years and younger who were ever diagnosed with asthma in LA County from 2002 to 2023. Over the last 20 years, rates of childhood asthma diagnosis have decreased across the county, and it's now at about 1 in 10 children. But the impact of childhood asthma is not the same across all groups. This slide shows the rates of childhood asthma in 2023 by poverty level, with 0 to 99% of the federal poverty level being the highest poverty group. We can see that children living in the highest level of poverty have the highest rates of diagnosed asthma. And then similar to the diabetes and hypertension examples for adults, childhood asthma can also result from a combination of factors, and there are inequities in the conditions that lead to disparities in childhood asthma. For example, exposure to secondhand tobacco smoke is a risk factor for asthma. Here we can see that, just as with asthma rates, children living in the highest poverty level also have the highest rate of exposure to secondhand smoke. This is an example from the survey of a potential policy intervention area that could lead to reductions in asthma outcomes. This slide shows the percent of adults with obesity in LA County from 1997 to 2023. In the health survey, adults are categorized as obese based on their self-reported weight and height. Obesity has been increasing in the county since 1997, with almost 30% of adults in 2023 categorized as obese. And then this is another condition in which we see inequities. This slide shows the percent of adults who are obese in 2023 by poverty level. And you can see that rates of obesity decrease with increasing affluence. Now, in the traditional way that we've looked at reasons for health disparities in the past, we could look at health behaviors that contribute to the disparities, such as fast food intake, which is also highest among those at the highest poverty level. But again, that doesn't tell the full story. Food insecurity is also highest among those at the highest poverty level, with increasing food insecurity with increasing poverty. Fast food consumption, then, might not just be a health behavior that needs to change based on individual decision-making, but really a result of limited access to healthy food and the structures that make it difficult to access healthy food. This is further illustrated with data from the 2023 child survey. This slide shows the percent of parents, guardians, or decision makers who rated their community's access to fresh fruits and vegetables as fair or poor versus good or excellent. The highest proportion of those reporting fair or poor access was among those at the highest poverty level. So hopefully these data have given you an idea of the type of information that's available in the health survey, and then some examples of how it can be used. such as for finding local statistics and trends for health conditions and underlying determinants of health, for recognizing areas of health inequities for intervention, and for identifying potential areas for structural and policy action. So some of our next steps will include the release of potential reports focused on specific topic areas, as well as sharing of data sets and collaborative relationships with our partners. Charles Drew will be, of course, one of the primary. And we've already started that process actually with Dr. Vargas, and it was great to meet some of the medical students, some of the nursing students who hopefully will be working with this data in the future. We're also, in late April, we're also going to be releasing more granular data at the city and community level. So the LA County Health Survey is at the county and the service planning area level and the health district level, but a lot of decision-making happens at the very local level, at the cities and neighborhood levels. So we'll be releasing more granular data at the city and community level that includes many of the indicators from the health survey, but also additional indicators from other data sources. So be on the lookout for that at some point in April. And then I also wanted to share the website for the health survey. The data tables will be live on the website today, so you can all have a chance to look at the wealth of data. Like I said, a tiny flavor. I only have 15 minutes, so got to pick what I could. But there's a ton of data on there. We also have an accompanying brief report that highlights key findings for selected population, including additional breakdowns by like race and ethnicity and things like that. So again, I want to thank our health survey team, Drs. Kui, Dr. Hall, Dr. Shah, and the whole team that's sitting over there. Thank you for making this work possible. And then I also really wanted to thank the Charles Drew team for making this event possible, and for your just continued partnership that you've done throughout the years. I've been in the department since 2018, and from the beginning, especially during the pandemic, it was just amazing to be able to partner with you all and drive this mission together. So looking forward to more of that. And speaking of partnerships, this event on the CDU side, a lot of work went into it by Dr. Roberto Vargas, and I wanted to bring you up here.
So thanks, Rajmi, and thank you all for showing up today, and thank you, Dean Deborah, Dr. Ferrer, and my friends and colleagues here. This is their show today, so Aziz, I don't have slides. Can you believe it? Not because I wasn't allowed, but I do want to continue to maintain the focus on the new release. But what I have been asked to do today was to talk a little bit about how that data gets used in partnership with academic partners and the Department of Public Health. When I met Dean Deborah in Boston, she was the chair, and I think the founding chair of the Department of Public Health practice at the School of Public Health. And I think that deserves a special mention, because I think we think about public health a lot in terms of data, and in terms of just, they're out there, and it's sometimes very amorphous to folks. But I think that the fact that there was an intentionality in the fact that the use of public health data to actually connect that to action was something that stuck with me from my time there, as someone who felt it was very important for us to think about how we address health disparities and the actions that we take. Some of my students, and I think many of you have seen my slides, I have that slide that talks about research and its connection to policy. And I think we've got a very rough lesson in the past few years, and it continues, about policies being made in the absence of sound data, and in the absence of research and evidence and objectivity. And so our ability to have access to quality data, but also to use that to inform our decisions, is something that I think we really need to impress upon our students and those who are out there in the practice space. Yes, there was a gap in this report, and many of you have seen me use the report. I show you the slides from 2007 and then 2017, and because we can look at that by service planning area, and we can understand some of those disparities that we're trying to highlight and get you guys motivated to address. But there wasn't a gap in data. And so what you also heard was that during COVID-19, there was a lot of access to what was going on with the public health data. And many of you firsthand got a chance to use that data from our partners and partner with our data, with our partners at Public Health for action. From the very first release of the data, when Dr. Robinson in our GIS lab was showing where the cases were, and that there was, this gap in cases in South LA, and people said, well, oh, that's because there are folks traveling back and forth, and that's where, and they said, well, where are the testing sites? And then when we overlapped that, we were able to respond. And that happened on a Thursday, he presented that, and then on Sunday night, there was a call, and on Monday, there was a testing center in the parking lot, okay? And that testing center in the parking lot, when we got data, our students, many of you there who were students said, wait a minute, we have to go out into the community and promote this. And they put flyers up because they felt that the community wasn't going to hear about it through those traditional formats. And actually, when folks showed up, helped to register people on site and showed that when we did that, we got a higher percentage of testing. And it can go on and on and on, because when we got to the ability to actually provide vaccines, and I was honored enough to serve with my colleagues from the Department of Public Health on the Vaccine Equity Advisory Committee, and sharing that data through venues like the Sabbath Town Halls that Professor Aziza Verdano had on Sundays. We got folks from the county to go on those Zooms in those town halls and actually provide messages to our Latinx community with Martin Navarro. That data was there, and it helped us to make the case so that people could see the cases and that people could see where the gaps in the vaccines were, and to educate folks. We had folks from the Department of Public Health come and give talks to our providers and our community members, encouraging them to get vaccines, to leverage that access, the information, and then empowered us to take action. And then that went further on in our shared mission, not just of advocacy, but of research here at Drew. And when we actually had the opportunity to better understand things like vaccine hesitancy, the work that Dr. Bazargan and Dr. Sharon Cobb did, going out to public housing communities and having Zooms in the community, working with mental health providers and social workers to actually advocate and share that data with high-risk, vulnerable populations about the fact that, yes, the cases are higher and we're dying more. But yes, that the vaccines actually had some efficacy and that we need to move that efficacy into action. And that research not only helped to inform our communities locally, but has been recognized nationally at conferences about the things that we can do to help reduce these disparities. And so that when we look at all of these efforts and we bring this out into the community, and not only do we create the research, do we educate our community, but we also can move that into action. And I see Professor Davis over there. And the fact that we dusted off the truck that was providing HIV testing, and it was 35, 40 years old, and it was leaking oil. And it started up, and a big plume of smoke came out, and we were out there in Helen Keller Park. And I was like, what the heck is going on here? But, we changed the oil, we kept going, and were able to provide vaccines to people where they were located. But where to go was informed by where those cases were the highest and where we knew people needed to get vaccines, okay? And so how we use data for our mission, our four-part mission, of research, okay, of education, of delivering care, and of advocacy and social justice is very much intertwined between our institutions. So I gladly welcome our partners from the Department of Public Health to come and make this announcement today for so many reasons. And so this is a kind of a little midpoint in today's program, because Rosmi has shown you the new data that's out here. But one of the things that I impressed upon her and her team when they asked to come here and present was that we need to provide examples of how this data actually does get used for action and for advocacy. And so the second part of the data that will be shared today, and the next person I'll bring to that, it was Dr. Deepa Shah Patel. And she's going to come and give you some examples of how that data gets used. And then we'll go on with another presentation, some time for Q&A. So thank you again, and welcome to our visitors, and thanks for your patience for my students and colleagues.
Just one thing I forgot to introduce, a very important person from the Department of Public Health who just joined us, Dr. Anish Mahajan. So he is our chief deputy, and we're really blessed to have him here. He also supports the office where we're doing most of our research and the folks that are presenting to you here today. So I just want to make sure everyone knows him if you haven't met him. He was at DHS, but he's now with us, and we're very grateful to have him with us. Sorry, Deepa.
Hi, good afternoon, everyone. My name is Deepa Shah Patel, and I'm the Director of the Nutrition and Physical Activity Program at the LA County Department of Public Health. And as Dr. Vargas has said, I'm here to tell you a little bit about how we use this data to enter into unique partnerships, collaborate with various sectors and community members and institutions, and then really inform our programs and policy work that we advance. So just most recently, with the LA County Health Survey data from 2018, we released 2 reports in the last couple of years. The first one was food insecurity in Los Angeles County. You may have seen this, before and during the COVID-19 pandemic. This one was released in 2021. And then we had another report that was released more recently in November of 2022 that focused on sugar-sweetened beverage consumption among children and adolescents in Los Angeles County. Each report includes graphs and tables and the data, but then after the presentation of that data, we include these data-driven policy recommendations. And then as a department work together with other members in the community, stakeholders, school districts, healthcare organizations to help operationalize and advance and implement these policy recommendations. So today I'll talk to you a little bit, just a few data points from the 2018 data and how that informed the policy, the recommendations that we developed, and then some of the examples that we did to enter into unique partnerships. So few things, this is old data. This is from the sugar sweetened beverage consumption report among youth. 1 in 3 children aged 7 at least 1 sugar sweetened beverage on any given day in 2018. Sugar-sweetened beverage was higher among Black and Latino children compared to Asian and white children. And in fact, Black and Latino children have approximately double the rate of sugar-sweetened beverage consumption when compared to white and Asian children. There are some geographic inequities as well. Sugar-sweetened beverage consumption was lowest in the West Service Planning area. So these are areas of Santa Monica, Beverly Hills, and highest in South Spa, so in the service planning area that we are right now, at 51.6%. Dr. Ferrer mentioned something at the top of the presentation about creating false narratives. So I want to really point out here that this data that we see is not the result of any individual or household's choices that they're making. When we're talking about nutrition and food access, we're talking about the results of structural racism, systemic biases, historical redlining, all of these things, divestment in communities that have resulted in a lack of access in communities versus others. So when we talk about and present this data, we really want to make sure we contextualize and present that data with that context. So with that context, the recommendation necessarily wasn't that everybody should be drinking water as an individual recommendation. It was how do we create systems, how do we create spaces where there is access to fresh water, that is affordable to all, and looking at also other factors like marketing. Our first recommendation was to consider limiting sugar-sweetened beverage marketing in public buildings and spaces where youth are congregating. So that could be schools, parks, et cetera. Currently in LA County, there is a limitation on where alcohol and tobacco can be marketed within schools. So within 1,000 feet of any kind of school or park, there can be no marketing of alcohol or tobacco. So our recommendation, and it's consistent in research that supports this, that we're looking at predatory marketing that is happening specifically to Black and Latino youth that is resulting in higher consumptions of sugar-sweetened beverages. The next is to make drinking water safe, accessible, and free throughout communities and schools. So we're looking at making sure that schools have updated infrastructure. So when I was growing up here in another part of LA County, I remember there was a line of evidence of rusty sort of water that trailed from the spout to the drain, which doesn't make water really appealing, right? Especially for kids. And it doesn't make it look like it's healthy to drink that. So really encouraging schools to update and have water bottle filling stations, allowing children to bring their water bottles into the classroom and promote drinking that water. And then another recommendation was that any local city sugar-sweetened beverage excise tax can use the revenue that's generated from these taxes to address health and low-income communities. So there's been a lot of talk over the last 10, 15 years about taxation of sugar-sweetened beverages. Other cities and counties, jurisdictions have done this throughout the United States with some success. There might generate some revenue, but then where does that revenue really go? And we want to make sure that it goes back into the communities to support access to healthy food and water. So some examples of what we've done and who we've partnered with since the release of the report. The first is UCLA Resnick Center for Food Law and Policy. So we've been working with them over the last several months to talk about, first of all, is it even feasible to have a restriction on sugar-sweetened beverage marketing in LA County? We don't know. Is there a precedent? Has this been done in other jurisdictions? Is it a violation of First Amendment rights? So we're really working with them to kind of figure that out and have them give us recommendations and a roadmap for next steps. So they're going to provide a legal analysis and then give us specific recommendations on what we can do to advance this specific issue of predatory marketing. We partnered with the Southern California Center for Latino Health, which is based at USC, to host a 3-part event series. So the first 2 webinars were really focused on community collaboration and the power of policy. And then the second one was a film screening. It was a documentary called El Susto. It's focused on what was going on in Mexico in terms of the high consumption of sugar-sweetened beverages, marketing practices, and how that has resulted into skyrocketing rates of diabetes. At that event, we had over 75 community health workers, promotores, to be able to share these messages throughout the community, to talk a little bit about how people can engage and mobilize to work towards creating healthier spaces. We also partnered with an organization called No Kid Hungry, and they read the report. They said, we want to help. What can we do? We've identified some funding, and they decided to release a solicitation specifically aimed at school districts to help install water bottle filling stations. So there was some funding that went out and resulted in several school districts receiving funding to help increase water access for their students. And then my last example is that we're invited to speak at a coalition called Californians for Less Soda. So this is an organization that's really focused on ensuring that any ballot measure that's put on at the local or state level that really helps to ensure that the revenue that's generated, again, goes back into communities. So we presented the data, and of course at the Public Health Department, we're limited in our advocacy work. We don't really do that directly, but we definitely can be a partner by providing data that can help the advocates make the changes that they need to make. Looking ahead, using the 2023 LA County Health Survey data, we were very excited about this new data. One of the things that we are looking at is not only, as Dr. Shetgiri had talked about, looking at food insecurity, which the USDA defines by access by all people at all times to enough food for an active, healthy life, to looking at a more nuanced measure called nutrition security. Nutrition security is defined by the USDA as consistent and equitable access to healthy, safe, affordable foods essential to optimal health and well-being. So there's a slight nuance there that captures a little bit more about the connection to food and health, and focuses away less so on food sufficiency, but on the quality of the food. So we're just looking at the 2023 data. We see that, as Dr. Shetgiri has said, 33.2% of households in LA County are nutrition insecure versus the 25.4% of households in LA County that are food insecure. So we see a little bit of that higher percentage in nutrition security, and that for a public health department, for our nutrition and physical activity program, is so important because we're so concerned beyond food sufficiency, but really on the quality of food to make sure that it nourishes our body and prevents diet-related chronic disease. A few data points that I wanted to highlight. This is nutrition insecurity by race and ethnicity. We see that 60.6% of Native American Indian or Alaskan Native are experiencing nutrition insecurity, 41.1% of Latinx households, 40.3% of Native Hawaiian and Pacific Islander, 36.7% of Black or African American, and then compared to lower numbers, which are still high, but 27.9% and 25.7% for Asian and white households. And that, again, is when as a public health department, we're really concerned about these disparities and what we can do to help reduce them. This is a map that shows nutrition insecurity by service planning area. We see that the highest prevalence of nutrition insecurity is in the Antelope Valley, as well as South Spa, where we are here today, at over 40% of households experiencing nutrition security. We also are able to see the reasons behind not being able to eat healthy foods. The top two reasons are the healthy foods are too expensive at 80%, over 80%, and then I don't think I qualify for food stamps at 64.1%. There's also a variety of different, other reasons that we will be analyzing by geographic area that I think can help us really think about how we do programming and policy development. On the horizon, so lastly, I just want to say that we're really excited. We are planning on releasing a new report in the upcoming year that, under the leadership of Dr. Ferrer and Dr. Muntu Davis, who is our health officer, presenting, when we release these types of reports, looking at them in a different way, lifting up community voices to really humanize the issue, talking about that community-based organizations and other entities are already working on, so that we have a much more comprehensive report that's released by our department. So we're very excited about that. Thank you, everyone, and I'll turn it over to Monty Messick.
Monty Messick. I'm with the Tobacco Control and Prevention Program. I'm a program manager. I oversee our tobacco retail policy and enforcement unit. And I'm going to talk a little bit about how, well, first I want to talk a little bit about our program. We're funded by tobacco tax, Prop 56 and Prop 99, to reduce exposure to secondhand smoke, reduce access to tobacco products among young people, and increase access to cessation products and services. And as part of that work for reducing youth access to tobacco products and in secondhand smoke, we do a lot of policy work. And that is that we work with communities, and I think as Deepa mentioned, that we can provide information and education, and that Department of Public Health can be an important partner in this type of work. So similar to Deepa, I'm going to talk about two reports that have been very helpful in moving policy forward in LA County. Let me figure this out. The other one. Got it. Okay, first one report I wanted to talk about briefly is the Cities and Communities Health Report that was released in 2010. This report on the cover says cigarette smoking in Los Angeles County, local data to inform policy. So think about that for a second. This is a report from the LA County Department of Public Health that says to inform policy, and specifically to inform policy at the city level. Because as I mentioned, tobacco control policy, it happens at the local jurisdictions with through city, through city councils primarily. And so this picture on to the left of the report is former LA County Public Health Director Dr. Jonathan Fielding at a press event promoting fresh air dining to educate residents about LA City's smoke-free outdoor dining law in 2010. And the cities and communities report was used to educate LA City decision makers and was really important and actually broke down by council district. And it was a very important report, and I thought it was very helpful. Let's see if I can remember how to do this. So the report went through all the 88 cities and also went through LA City, broke down, I think there's 15 council districts. I won't go through all of that, but they had small area estimates showing what the smoking prevalence was for that particular city. And again, city decision makers, city councils, they're interested in what's going on in their city. So a lot of times they're not interested in SPA data or even county level data. They're interested in data that is specific to their jurisdiction. So there's these small area estimates that go through all the different cities, et cetera. Oops, went the wrong way. Sorry about that. It also included policy recommendations similar to the report that Deepa was talking about that were very powerful. One was to reduce exposure to secondhand smoke in multi-unit housing, restrict smoking in outdoor public places such as outdoor dining areas, reduce youth access to tobacco products by requiring retailers to sell tobacco products to obtain a license, restrict the sale of tobacco products through conditional use permits, and promote smoking cessation services. And the area that I work in primarily these days for the last 10 years or so has been reducing youth access to tobacco through policy work, and I'll go into that in a second. The second report was in 2018, the City and Communities Health Profile report. Similar to the previous report, went through all the different cities. I think it was a little bit more, it was a broader report, had multiple areas that it touched on, but it did have a section on tobacco use. And also, I highlight Beverly Hills here. I know that we're talking about inequities, and I'll get back to Beverly Hills in a moment. Because actually they did some very, very important work that I think moved the needle in terms of inequities in tobacco control. And this report also included a section that also made direct policy recommendations. Cities and communities can take additional action to reduce youth access to tobacco products by promoting zoning and licensing restrictions, to regulate location and density of tobacco retailers and vape shops, particularly in youth-sensitive areas and vulnerable neighborhoods. So again, this is a Department of Public Health report with policy recommendations in it for tobacco control that actually mesh with the work that we're funded to do by the state of California in our Prop 56 grant. And I don't know if I should say this with Dr. Ferrer here, but once you have a DPH report like this, then it gives, maybe I shouldn't use this word, cover to staff to be able to say, look, the department supports this. And so then it gives a lot more latitude in terms of what we can do. Obviously, we're not there to lobby, but we can provide much more information and education. So, well done. Thank you. Amen. Yeah, you're preaching to the choir. But thank you. So a couple examples of using this data in local policy work. In 2021, the Alhambra City Council voted to ban the sale of flavored tobacco products, among other policy provisions. Alhambra's community health profile was used to educate decision makers in that effort. And this is a Alhambra City Council member joined by a community-based organization at a health fair. So it's very useful there. And then LA County Health Survey to engage decision makers. So in Beverly Hills, the Beverly Hills City Council voted to ban the sale of flavored tobacco products in 2018. The Beverly Hills Community Health Profile was used to educate decision makers. And the reason why I brought up Beverly Hills is that in 2018, when this policy was passed to ban flavored tobacco products, a lot of opposition to it. They were one of the first jurisdictions in the county to include menthol in their flavored tobacco ban. Until then, some jurisdictions banned the sale of flavor but exempted menthol. And this is important because it's menthol is a product that tobacco product that the tobacco industry targets Black communities, LGBTQ, and young people aggressively. And so you'll see here there was Beverly Hills Health and Safety Commission that were really important moving this forward, joined by community members, health advocates, DPH staff after the vote. In particular, I wanted to point out that the African American Tobacco Control Leadership Council took a very, very strong position, was very, very involved in this policy because of the inclusion of menthol. This policy led towards other jurisdictions, including menthol, including the county, under Dr. Ferrer's leadership, banning the sale of flavored tobacco products, all flavor, including menthol, which was really big. Which also led towards the state of California, as I'm sure you're aware, has adopted a ban on sale of flavored tobacco products that includes menthol. All these products also are designed in such a way that it's the sale, not the possession. So that way that people that are using the product are not targeted by law enforcement. And it's very important. Uh-oh, I lost it. I don't know what happened. Let's see, maybe it went to sleep. I don't think I had one more slide, I think. Oh, it shut down. I had one more slide. I'll just talk it through. Anyway, the last slide I had was just to talk about how many policies have been adopted. And unfortunately, without my slide in front of me, I don't have the numbers, but many, many local tobacco control policies have been adopted. And I believe that a lot of them have used data from the Department of Public Health, including these small area estimates. So thank you for your time. And with that, I'll introduce Dr. Ferrer. Thank you.
Oh, yeah, thanks so much for the wonderful presentations, Monty and Deepa. I appreciate it. And I appreciate your willingness to come here and sort of share the stories. And, you know, of course, these are stories about what we did with past data. I think since 2018, we've been, you know, very certain that the use of sort of either moving policy or practice change cannot happen by ourselves. Like we understand that intimately now. I think one of the biggest lessons we learned during COVID was the public health infrastructure is not the public health department. It is the public health department plus all of you, our community-based organizations, our faith-based organizations, community leaders, and residents. And that's the investment we have to make. And one of those investments is making sure that when we have information, we're actually sharing it so people actually can look at this data and make their own decisions. And then also look at this data and see how it resonates with their lived experiences and the stories that they want to tell about their lives and what's impacting their lives. So I appreciate, you know, so much your coming up and sharing. I think that was great. We have a couple of minutes for questions. Love to take questions. I'm not going to answer many of them, but because there's amazing talent here. But yes, Dr. Prato-Smith.
We're in an unincorporated area, and obviously some people also live, even though they may not work in unincorporated areas. So we don't have here in Willowbrook or in other places that city layer to add resources and policy. How does the county deal with that?
Yeah.
What is the extra effort or funding that is available?
Well, this is how I think of it, and I'm not an elected person, so I'm going to put that caveat. If you're in the unincorporated areas of LA County, then essentially your supervisor for here is Supervisor Mitchell. She's like your mayor. And the county infrastructure has to support the activities that happen in unincorporated. That's how it's set up. I think, you've got an amazing supervisor here. She actually has gone ahead and created she sends it out every week, a newsletter for the unincorporated cities and towns so that they know what the resources are that are going to be available to them. But that is the infrastructure. And there are, I think, don't quote me on the number, I think there's over 100 unincorporated areas compared to like 80-something cities. So the unincorporated areas do need to rely on the county's infrastructure. So I see some people standing at the mics. That's awesome. Thank
I
you.
don't know if it's on or not.
But we'll take hands as well.
I did want to thank you again and inform you that Department of Family Medicine initially was engaged in developing the questionnaire in 1997. And so you came back to the right place. Thank you. You come back to the right place. Thank you very much. My chair is here and she knows that. And then I have one request, see if you can consider that one. Indeed, two.
Yeah.
One is that if it is possible to use a sample of your data and conduct longitudinal. So from each household, maybe select 1,000 of 9,000, then you can see a better trend that what is happening within the family, because 1 out of 4, to the best of my recollection, people who live in county of LA moving around. They go to Lancaster, they go to the other county, and that longitudinal study may represent a better way to document the progress that your department and LA County made in the health of residents of this, beautiful county.
I love the suggestion, it's kind of like a cohort study. I will tell you what we are trying. It's a little bit different. It doesn't come out of the Chief Science Office, but it's trying to get at us really being able to intentionally look at some changes over time. We have, with our partners, we have a health clinic and we have a community organization partner in 10 under-resourced communities in LA. We call these our community public health teams. They have a catchment area that they've defined. It's somewhere between 9,000 and 12,000 households. They have teams. Every single household will get visited at least once a year. And there is a survey instrument. It's really meant to be helpful, find out what services and support families need. But over time, we would like to, with the permission of community residents, be able to collect not just, their thoughts, but actually use some biomarkers. The intent there is to bring those smaller neighborhoods together, not just connect people to resources. We learned from COVID that lots of people may have insurance, but they're not actually connected to the care, and lots of people were not connected to services.
Great.
So one thing we want to do is that, but the other thing is this is an opportunity for our community organizations to do some organizing. And they're responsible for bringing those community residents together periodically to assess neighborhood conditions that either can support good health or are detracting from good health. So it's an elegant model. I want to give a lot of credit to the community teams. It's 5 years of dedicated funding right now. Our hope is that we will be able to track some health outcomes because we think the insurance companies, frankly, should be paying for this.
And the second request, Madam Director, is that if your office could provide us a code book of your data with all frequency. Me as a with all frequency. Me as a researcher, when I want to analyze the data, then I look at the frequency, see what I want to propose is possible or not based on the frequency, etc. The code book is extremely helpful to us. We have a committee here which is called Secondary Data Analysis. We meet periodically, analyze the secondary data, and I think we can substantially contribute to publication of your data if this is provided. Thank you very much.
Remy, is that possible? Okay. Okay. We'll get back to you, though. Yeah. Have clue, yep. Yeah, okay. Okay, yeah.
So how will we be able to access it? Will it be online, or will there be hard
Russian.
copies available? How are you going to distribute it? So one discrete document is what I'm asking.
We're not printing this, it's.
Can we download it?
Well, you can download it, yeah. We're not printing it because we think different people want different parts of it. Yeah, you can manipulate the data set. That would allow you to manipulate the data set, which is our goal here.
Thank you.
So, I know there's a question in the back. I mean, yeah, maybe come up, Rush. I do want to preface it by saying I'm glad you were using that data. It was a big project we started when I first got here as a way for people to, we really wanted people to just take that data, add to it, put stories to it, and use it at the neighborhood level to really capture what's going on.
So I can talk about like how that basically comes together. And we are going to be releasing the next iteration of that at the end of April. So yes, so that'll be good. We're actually going to be doing that on more of an interactive platform rather than the tables, but you'll still be able to print all the PDFs and all of that. So there, with the LA County Health Survey data, this is the county level data, but the team over there does a lot of small area estimation to generate the city and county level data for each of the indicators. And then some of the other data that's not coming from the LA County Health Survey, some of that is already collected at the more granular levels, and so we're able to utilize that granular data from programs across the department. So it's really a department-wide effort for, and then sometimes we get other data sources that are not even our departmental data sources, and we look at that data and we need to manipulate it in different ways to generate the data at the city and community level. So there'll be like over 100 indicators in that coming up.
And there's how many communities this year?
How many? 181, yeah.
181, so for the unincorporated.
You have, yes. We got a lot of requests actually for, since we did the last iteration, that, for folks very legitimately who said, our communities are not appropriately represented here. It's really mainly the cities, and so we did a lot more work on the unincorporated neighborhoods. City of LA, we did the council districts. We also did more areas within that as well. Or will be doing.
Yeah. Oh, no, thank you. I do want to make an offer because we really do want people using the data and manipulating the data. Once we launched the community level data in April, we're happy to send somebody. I mean, I don't know that we could do it for every class, but if you organize yourselves in a like symposium, we can send one of our brilliant, sort of data folks that are here, our EPIs, to help you manipulate that data set, to show you online exactly how to go in, create reports. That's the goal here, is that we don't create the reports for you. You have access to the data. You could look at it, and then you decide, which information is going to be helpful for you. And we're happy to send some of our staff to come and support the learning, because we think it's really important that people use it. Yeah, absolutely.
One other thing that I did also want to mention, what you just said about we use the data and this is how we use it, that is really important for us to hear. That's really important for our community to hear. And that is part of the reason why we're doing, the engaging with you all is really important, because that's how we find out what do you actually need? What is it that we're not putting out there that you need? How do you use this information? How do we change what we're putting out there based on how your needs are changing, right? So that the only way for us to get that feedback is to engage with you. So thank you for the invitation. We're definitely going to take you up on it.
Yeah, I think we have time for just like a couple more questions. So, but I'll go to you and then behind, or whichever order you guys are in. It's such a great question. One of the things we did on the first round when we released this data, I think 2019, was we actually spent a fair amount of time working to train some of the community field staff so that they felt pretty comfortable with the data and they could actually do presentations in the community. Would that be helpful, do you think? Uh-huh. Yep. Yeah, I mean, we're wide open to your suggestions. I mean, we can do what we did before, which is, allow everybody to get trained and feel pretty comfortable with the data for their communities. You also could suggest that, somebody show up and help you meeting. I mean, what we really want is people to look at it and say, this resonates, this doesn't, and we need data. You're missing data on a problem that's really important for us. So help us figure out how we're going to get that additional information. I want to say, we can present this with the information that's already collected, but you all know some information just isn't collected. That's really, really important. And that's why we want communities to tell stories. We've encouraged people, if you are printing it, have a section where you tell stories about what does health look like in that community. Don't just rely on the numbers here, because they're limited. I mean, you all know that already. I'm telling you something you all know. Like, we make choices about what data we're collecting, and we're missing some data that's probably pretty important for people living in communities. So, but I appreciate you, and I appreciate your question. So, thank you. I love that. Thank you. Thank you. And we're going to, I know some of us are late. We need to get going, but I want to appreciate all of you. Our special thanks to our hosts. Dr. Vargas, Dr. Prothero-Stith, and to all of you for coming. And again, definitely reach out to us if you want us to come and do more in your classrooms, in the community. We're here to help with that.